Hey, Shep, how are you?
I'm good,
We've
mate.
got a fantastic guest on the podcast this week, pediatric emergency physician, Dr. Claire Wilkin. She's done just about everything there is in the space of critical care and pediatric emergency medicine, hasn't she?
Mate, she's fantastic. I've known Claire for probably 20 years now, I think, in total. Gave me some education with my intensive care course many, many moons ago and has remained actively involved in the pre-hospital environment. Works alongside Ambulance Victoria now and works as one of their paediatric medical advisors. And she's wonderful. She comes and delivers lectures for the intensive care students or interns as they're going through their course. Very enthusiastic and is very patient focused. Loves education, loves being involved with these type of podcasts that we do. So she's happily agreed to come and have a chat with us. And I think the chat that we do is going to be amazing, and I think everybody will really, really enjoy it. So we are super excited to have her on board. She's committed to not just this podcast, but more podcasts in the future. So if people want to know anything more about pediatrics, get in touch, let us know. We can do a podcast with Claire.
Yeah, no, we definitely got to have her back on. We will, in this episode, talk about why pediatrics, why medicine, her path into all this, and then some really sort of bedside tips and tricks at the end of the bed, I reckon.
Yeah.
If people listen up, they'll walk away with half a dozen great phrases or sentences that they can pull out when in need in challenging situations, as well as all the other good pediatric emergency medicine
absolutely.
stuff. So, great episode. Tune in, play the song.
Hey, we're on. We're on. Hey, welcome to Pre-Hospital Nerds for another session. I've got Alex with me again, obviously, and I have the pleasure of introducing Dr. Claire Wilkin, who has joined us today for a chat, all things pediatric.
That's the one.
Claire, welcome.
Thank you.
It's great to have you on board. So, Claire, I think I'll start by launching into why pediatrics, why medicine, why are you here? How did you get to where you are right now?
Oh, that's a long story, but I'll keep it very short. Why medicine? I was young and very silly and didn't really know what was ahead of me. So I started med school at 17. So have I ever known anything else? No, I haven't. Would I do this again if offered the choice? That's tricky. I certainly wouldn't encourage my own kids to go into medicine. It is something that you have to really, really want to do. And I think there's a degree of saying that a bit of life experience is good for people before they make the decision to go into medicine. You know, it's been said before, but medicine will eat your life. And there's certain situations in which it takes a lot more than it gives. So, it's something that you really have to have a passion for. And if you don't, it's not something that you do just because you get the marks or because mum and dad said it was a good idea. Why pediatrics? Adults lie too much is the short answer. Kids also, it's a bit more diagnostic. Like you've got to think a bit more clinically. I love clinical medicine. I can't stand standing around waiting for investigations and cheating. Most of the information that you need from a patient is in the history and the examination. So if you're sitting around with no idea waiting for your investigations, it's probably not going to get you where you want to be. And pediatrics is awesome for that because even when you get complex problems, a lot of the thinking is in the history and the exam. But also kids are super fun. And they also come with dedicated caregivers most of the time who are just a wealth of information. And while parents can be tricky, I don't think anyone's going to deny that, they are there for the benefit of their child and they're really dedicated carers, and they just, getting them on side can be tricky, but it's also part of the job, and it's very much something that you can learn to do if it doesn't come naturally. And I just think kids are awesome.
Very good. Very good.
With this level of honesty, the next 30 minutes is going to be fantastic.
Always. I'm not here to tell lies. That's just boring.
So, maybe I could say for people who don't work with the kids all that much, like, why is there a specific pediatric emergency? Like, we certainly, see people of all ages and different illnesses. Why do we have to have a pediatric specific one?
It's a really great question. So what we know is that actually most children will never meet a pediatric emergency medicine specialist, and that is absolutely fine because most of them don't need to. The vast majority of kids in Australia are cared for in emergency departments by perfectly qualified FACEMs who have done sufficient paediatrics to really offer great care to many, many of our children. But there is a sub-cohort of kids who do need subspecialist knowledge and intervention. And that's, a big reason why the PEMS are located inside big tertiary hospitals, but also why for many, even regional centres, having one or two PEMS on staff is just an extra person to have a chat to, or if you are coming into contact with some of those kids that are a bit more complex or not as straightforward as we would like, it's just kind of an extra brain to say, hey, what do you think about this? I'm thinking X, Y, Z. Have you got any other ideas? So it's not to say that, general FACEMs are not more than capable of managing children, because of course they are, in the same way that they're more than capable of managing, people within all other ages of life. But just like in the elderly, there are some specifics that are, nuanced to that group, and really having subspecialists in that cohort makes a big difference to their care that those kids can receive. It's really the same as any other specialty. You can be a general cardiologist and be amazing at managing all cardiology problems. But if you've got a specific rhythm disturbance, who are you going to see? An electrophysiologist. So it's kind of the same concept, but I think emergency medicine maybe has been a bit less comfortable with embracing that, just because, we really see ourselves as being across, all ages and really capable, which general FACEMs absolutely are. But it's just when there is those extra nuances, having somebody else to bounce the ideas off is really where the benefit is.
So, because I'm ignorant to all of this stuff, did you have to do emergency adult medicine first before becoming paediatrics?
Yeah, so there's two streams. So PEMS are either what are called FACEM PEMS, which means they've gone through the emergency medicine stream primarily, so within their basic training, and FRACP PEMS who've gone through paediatric training before they reach paediatric emergency medicine. So you can have two separate basic training schemes, which depending on the clinician is, 3, 4, 5 years worth of basic training. Going back a step, everybody does adult training initially, or sort of general training where you might see some paediatrics, but there's no paediatric specific training in the first couple of years. For me, I did paediatrics first. So I did my paediatric basic training and my paediatric exams. The short version was I really hated clinic. It was awful. I was like, oh my God, I can't do this for the rest of my life. So I had to find something else to do. So I actually went across to do adult emergency medicine training as well as paediatric intensive care training, and then paediatric emergency medicine training. So how's that for total inability to make a decision? Wow. And then I trained in paediatric ICU right up until sort of exam point. And then I kind of went, I've got to make some choices here. I can't actually do all these specialties permanently. So then moved permanently into the paediatric emergency medicine stream. But I've done quite a lot of adults during that training as well. And then I've kept my fingers and toes in various other pies that allowed me to still see some adult patients. So there's different pathways, and now it's a bit more structured even than when I did it. But we hold dual fellowships, so we hold a primary fellowship with certification and sort of acknowledgement by the other fellowship group. And the training in the end results in PEMS who really are very, cross-cultured across both groups. Some will have different strengths and other things that they find difficult, but that's the same as everybody. You can speak to plenty of general FACEMs who say, gee, I really don't like eyes.
Yeah.
Or I'm not really down with kidneys or whatever. And I think that's all of us, right? We've all got strengths and weaknesses. And that's the same for the PEMS. We, a few years ago, asked our junior staff to actually work out who amongst the consultant staff were FACEM PEMS and who were FRACP PEMS. No one was allowed to look it up. They had to guess based on having worked with us. And they were wrong about 40% of the time.
Yeah, right.
So their assumption of who did what was not always accurate. Yeah.
I think you're very true there, because everybody has a specialty that they enjoy or something they enjoy. Everybody has an interest in ECGs or an interest in fracture or
100%.
what it is. So it's just finding your little niche that you actually enjoy. And then the biggest thing for me with that sort of stuff is that education and learning becomes very easy once you find an area of specialities.
100%. And I think the other thing is actually acknowledging that we don't all know everything about everything. And there's, everybody's got things that they're less comfortable with, and acknowledging that sometimes you're going to have to phone a friend. If you come up against something that you go, yeah, I kind of feel like it's probably this, but not really solid here, phone a friend. That's what friends are for. So it's kind of that, it's just being able to acknowledge that and having enough confidence and enough kind of lack of outward ego to say, this is something I'm just going to get a second brain on to back me up here. And I think that applies to everybody.
I have got a perfect segue from this, Claire. So if you don't mind, Alex, I'm just going to launch into Well, I think what you mentioned there is really important because as a profession, paramedics in the past have been very ego-driven about I know everything and I should know my guidelines from cover to cover and I need to know it so well that I don't need to call on anybody for any assistance. But I think we've evolved and hopefully we've matured as an organisation and a profession that we should now recognise if we are certainly in situations where we are out of our depth, that we should call on people. And so you have a role now, I believe.
I'm the director of Retrieval Service to ensure that they're getting to the right place at the right time, but also trying to ensure that where possible, patients can get care they need closer to home. So not everybody that is unwell needs to move to a tertiary centre. We have some very, very capable regional hubs, particularly, who are working really hard on upskilling and really are very capable at managing many of these young people. And so it's about maximising the capability, the capacity and the support that those centres have to continuing managing children that are well within their skill set, but then also making those calls to say, actually, these patients, this particular cohort need to be managed in a tertiary centre, and then ensuring that that happens in a safe way. Sometimes the desire to kind of move a kid out of somewhere because people are starting to feel uncomfortable will somehow manage to kind of override what is actually the best thing for this patient right now. Sometimes it might be staying in a smaller regional centre for a short period of time for stabilisation before we put them in the back of a truck or a helicopter or a plane, which is always going to be a less resourced environment than pretty much any of our EDs in the state. So it's about making sure that those patients are really safe and able to be managed appropriately during transfer as well. We can't be dropping standards of care during transfer when people are just sort of not feeling comfortable when we've got the capacity to provide that extra support. So yeah, that's kind of my new hat, which I sort of added with the other hats. They're kind of all sitting down the side now. I am running out of head, but that's okay.
So much.
I know, right?
You've done. Yeah, good thing you started studying medicine when you were a paediatric.
Yeah, correct. When I was a child, that's exactly right.
Less than 18, less than 16. What is PED? Some guidelines would have less than 14 and other places.
Yeah, it's really interesting, isn't it?
Whether you work or not.
Well, that's it. And often it depends on where you are.
Yeah.
So there's different places around the world that will absolutely take different viewpoints and there's no right answer. So, in Australia, we say, well, if you can vote and we're saying that you're a competent adult, well, you're 18 years old. I think, for those of us who know some 18-year-olds, there are some that are maybe not quite in that space just yet. And so it's completely arbitrary. Yeah. At what age are you physiologically an adult? Well, that depends on whether you're counting frontal lobes or not, because we know that, young women and young men, particularly young men, frontal lobe not really fully operational till, earliest 25. So should we count them as children? I don't know. Like it is really difficult because adolescents and young people do have they've got a different brain, they've got different bodies, things are very different to what happens in adults, but the differences lessen over time. And at what point do you make the call and say, well, actually, you're close enough to being an adult that we can comfortably say most adult things will apply to you? And I think it does depend a little bit on what you're talking about in terms of whether it's trauma or medical conditions or, there are certainly things that are best managed by a paediatric service for much longer than perhaps other things. So complex congenital heart disease, for example, will often remain within the remit of the paediatric cardiothoracic surgeons for much longer than it might do otherwise. And that's because the survival rates of those patients have changed a lot in the last sort of 10 years or so. And so it's, you have to give some time for the adult cardiothoracic surgeons to upskill in a patient population that they hadn't had a lot of exposure to before because the survival rates were different. So it kind of depends who you ask, is the honest answer. All hospitals and all the state systems have this is the answer and this is because we need to have a guideline so that people are not left kind of sitting on the side of the road going,
yep,
well, this patient's got this condition and they're this age, so hold on, let me look up in 7 different places which hospital I'm supposed to take them to. So the guidelines are sitting there in order to try and make it more straightforward, but none of it's perfect.
Yep, 100% agree. Because the last thing we need is confusion. Like if you're at a scene and it's busy and there's a lot of stress and a lot of emotion, the last thing you need
100%.
is ambiguity with guidelines as to what you should do. So definitive things are really, really important. Now, I'm going to sort of step away slightly. You mentioned something before about maintaining good levels of care through transfer and all that sort of stuff. I'm going to pop a little scenario out for an in-hospital transfer for a child with DKA, 12 years, 13 years old. Dextrose insulin infusion, needs to get transferred to a major tertiary centre. He's in ED, has got doctors, nurses looking after them, and then has been transferred to the ICU at Children's Hospital. What sort of level of care would you believe that person needs? Like, we're going from an area that's got doctors, very well trained emergency nurses, through to an intensive care department. Do you believe that level of care should be continued through, or is that something that we can just put with ALS crews or with non-emerge crews? What's your thoughts?
Yeah, they're always difficult, and I think it is an individual patient decision because there's a degree of, obviously, the patient's baseline diagnosis, DKA, very volatile. Is it the patient's first presentation, in which case they often are, they can be quite tricky to manage? Or is this a young person who's had multiple episodes of DKA, and we know that there's a number of risk factors for the development of things like cerebral edema, which we would obviously want to avoid in a transport context. So there's components about the individual patient that contribute to that decision. Is it an ALS job? No, it's not. That part is relatively straightforward because we can't reasonably ask ALS paramedics to be adjusting infusions, and that's not something that sits within their guidelines. So that gets quite difficult. So unless a patient has been very stable and, it's a relatively short transfer, etc., I wouldn't think that's something I would be particularly comfortable with. If it's a patient coming from a rural environment or a regional centre and there's a longer travel time, so say a couple of hours, either by road or by air, depending on the appropriate platform, then it's something that either one of our teams would go and collect or would be on call to whoever the service was that was providing that care. So whether that's Air Mica or alternative, we would expect that any challenges that team experience with the transfer, they could call back to us. It'll always come down to things like team availability, platform availability, and appropriate staffing mix. And that's why we have retrievalists, because we want them to be part of that decision making. So rather than a regional hub ringing the endocrinology service at the hospital, which can be two very, very different environments, and the appreciation of each of the other is also not always clear, to say, oh, will you accept this patient? Yeah, no worries, just send them down. Now, patients unfortunately do not have access to Harry Potter portkeys, so they don't just materialise in the place you want them. There is an entire process that happens between those two things, and that's really where we ask the retrievalists to be involved, to say, let's help coordinate these logistics. They can understand the different skill sets of different levels of paramedics. What might be appropriate for one group to manage in a certain circumstance may not be in a different circumstance. Also around the specifics of this patient and what is likely to be their course over the time that they're in our care, and then where is the appropriate destination, and have we sorted that out? Because again, patients don't miraculously appear on the endocrinology ward without going into either ICU or the emergency department, and we need those clinicians on board with those conversations as well. It's always more complex than people imagine it to be.
Yep.
Sometimes it's like yesterday and it is pouring with rain and, nobody's going anywhere, quite frankly, because there's flash flooding everywhere. We can't fly. So there's lots of other logistic implications that kind of come into all of these decisions. Sometimes patients still have to move and we have to make do with what resources are available. And other times the safer option is for them to stay where they are until we have a safer path to move them on. So that particular patient would certainly be something that we would expect would be discussed, and then we would definitely be part of the, assisting with moving that patient and ensuring that they're stable and appropriate during transfer, however that decision ends up being made.
Wonderful. That's such a good answer. And I think that's really important for all the clinicians out there, that if ever they find themselves in a position with a transfer that they feel may be beyond their skill set, is obviously consult with somebody. So consult with the retrieval body, involve that second person and get a second opinion and sort of help allay your fears. I think that's really important.
Oh, absolutely. And it's really just about sharing it, isn't it? It's just saying, actually, these are the things that I'm looking at the patient physically because they're in front of me, whereas I'm, far off away, and I can see these things that you might not have been aware of because you can't see them.
Yep.
And if I have that extra piece of information, maybe it does change the situation and maybe I do have to make a different decision. But it's really about sharing that information and working together. And I think the most important thing, and you mentioned ego before, is about actually nobody cares about any of our egos because it's all bloody irrelevant, to be perfectly frank. It's about the patient, and it's about where is the patient best managed and how can we, as a team of individuals caring for that patient, ensure that they get the right care in the right place. And even where there's a difference of opinion or where people feel very strongly about something, it's completely fine to express that, but obviously being respectful and appropriate to our colleagues at all times. And that's on all sides. You mentioned that sometimes, before paramedics have had that kind of real stringent approach to the guidelines and can be quite firm in how they get that across. But doctors are not unique and special. They absolutely are responsible for some of those poor interactions as well. So it's really about accepting that there are different skill sets, all of which are critical in managing the patient in front of us, and we absolutely have to work together or patient outcomes are not good.
One more thing I'm going to add, Alex, before you jump in, because I can see you've got a question on the tip of your tongue, just waiting, is that some hospital transfers we have to transport. Like, even though it's outside our skill set, there will be a clinical urgency with the patient that sort of dictates that person needs to move now, because if they stay where they are, they're going to deteriorate and die. So sometimes I would still encourage strongly that people consult with the body that's within their organisation to assist them with that transfer. But sometimes you are going to be put in positions where you are going to be a little bit uncomfortable. And be prepared to do that, but also consult when you are in that situation as well. Alex, go for it. I won't take any more.
Yeah, no, that's great. I love that discussion. And I think it's interesting how the reason for sort of being careful with this stuff is physiology, I guess, rather than politics, because maybe you could tell us a bit, why do kids look well and then 2 minutes later they don't?
Yeah, you know what? Yeah, absolutely. And they're fantastic at that, aren't they? It's that kind of people go, oh, but the obs look okay. And, we've got these great Victor charts that help people to identify, when those observations are sitting out of range. But with certain populations, by the time you've got obs sitting out of range, you are so far down a spiral that it's very, very difficult. So I think it's more about looking at the patient in front of you, thinking about what's actually going on for the patient. Pattern recognition is great. Tachypnea and cough and fever makes pneumonia. Okay, so we can do that straightforward pattern recognition, and that's great for lots and lots of patients. But actually, sometimes if a patient's not behaving in the way you expect, or you just get a bit of this kid's not right, they're not doing what I expect them to do, or the mum's really insistent that they're quite sick, even though I'm standing here and I feel like they look well. It's about, again, putting your ego out of the situation, and it's not about being right or being exactly correct with every single patient that you meet, but it's about acknowledging that there's something not quite right here and I need to look at this carefully and in more detail. And in paediatrics, we talk a lot about things like serial examinations, where we might go and look at a patient and say, yep, that all looks pretty good. Obs look normal. Patient's smiling, or patient's on their phone. That's always a classic. And we're examining the abdomen and going, yeah, it looks pretty soft. They're saying they're a bit sore here, but, it really looks pretty benign. Now, you could make an argument, okay, well, that's all very benign and see you bye, patient, catch you next time. But actually, if you've still got lots of concern coming from the parent, the patient telling you something, or there's just something where you go, it's a bit odd, just say, that's fine. We're just going to see how you go for the next hour or so, and we're going to come back and examine you again. Now, obviously, that's an emergency department rather than a pre-hospital capacity. You can't take your ambulance down the road for a cup of tea and come back in an hour. That's not going to be practical. Well, hopefully not. But it is that kind of serial examination. And if there is that ongoing concern, just to sort of acknowledge, well, I don't really know what's going on here, but this is something that I want to watch over a longer period of time to get a sense of what's happening. Kids will amazing compensatory mechanisms, which actually last longer than we probably give them credit for. I reckon there are plenty of adults pushing into their 30s and 40s who actually have really quality compensatory mechanisms, but we just let them go for way longer than we ought before they start decompensating. But we're so used to that early decompensation in sort of the elderly and vulnerable populations that we kind of apply that throughout the ages, and actually kids will compensate for so long before they don't, that it is trickier. But as long as you're aware of it, I think it's a lower risk, right? If you're aware of something, you're much more likely to go, actually, I think it's that thing that chick talked about that I saw. I reckon it might be that I've just got to watch this kid for a little bit longer to try and work out what's going on, or phone a friend if I'm really not sure.
Wonderful. That's so good, because you can lead me straight into this next segment now.
Oh, I totally did that on purpose, yeah.
The paediatric triangle. When we talk about being able to recognise the child that's actually unwell, and you've talked about the trajectory of the illness and the pattern of the injury and whatever else it is that's got going on, but we can use something like the paediatric triangle straight off to help us determine who is well and who is unwell, and then we can monitor that as we continue our management of the patient. So can you speak to us with regards to the paediatric triangle, and what are all the sides and how does it all work?
Oh God, now you're testing me. It's sort of one of those things I think that is really useful, I think, when you're learning how to do it. But if you ask a lot of senior clinicians about it, they'll kind of be like, yeah, I do it all automatically.
Yes.
Right. So there's a component where I think which is important for all patients. I think the pediatric triangle is obviously important for pediatrics, but actually you can apply it pretty much to everybody when you're standing back and saying, what can I actually see about this patient? So what components of standing at the end of the bed and looking at the patient before I rush in are evident to me? Does the patient look well or unwell? And if I answer that question straight off the bat, what is it that's guiding that kind of principle? And then it's about getting that history and trying to work out exactly what's happened, as you said, and pinning that down to what it is that you think is going on today. Some families and some patients can give you a history that goes for an hour. That's presumably not what brought them in front of you today. And it's about synthesizing and pulling out the bits of information that you need and then combining that impression with the observation, with the history and the examination to kind of come to your synthesis in the middle, which I think is a little bit different actually to what we sort of teach from a pre-hospital perspective around the triangle, but the principles are kind of the same. It's about putting all of those components together to say, this is our overall impression of what's happening with this child, and ensuring that you don't leave out any of those components. Like if you're just taking obs and just asking mum what has happened, you're missing out components of that assessment that you need in order to move forward. Does that?
Yeah.
Without going through the details.
That's good. So it's all about how they look, yeah? Like, we've said that. And when people call, that's just a frown at the moment, isn't it? Is there any thoughts or plans, or see if we could borrow some of the equipment from our stroke colleagues? Because certainly I'd much rather have you at the other end of a FaceTime sort of video call with a sick kid when I work in a rural ED, rather than having some neurologist look after a 100-year-old with a little facial droop. I'm much more comfortable dealing with that myself.
Yeah, of course. Yeah, exactly. So the answer is absolutely. It was, I had a list of a handful of orders of business when I started a couple of months ago, and that little gem was number one. Yeah. So the answer is yes, we will have video conferencing available. From a paediatric perspective, we can really do it using systems that already exist, as you mentioned. So not specifically the stroke system, because that is actually a little bit more complex than even we need. And when we're managing patients in, for example, urgent care centres or very small remote clinics, they may not necessarily have access to the stroke setup. So it's even more straightforward than that. But we have additional modules coming in that allow us to have cameras on site that we can actually control remotely to visualize patients. Again, that's sort of more of an infant-specific program, but the simulations are up and running. We're running paediatric simulations in the next couple of weeks, and once that's up and running and we've confirmed that all of those things are going to operate as we would like them.
Yeah, exciting, and maybe this is something that could be called from the field as well one day.
Yep, that's the plan.
And that was pretty much answers my next question, which I was going to throw at you then, Claire, is about, well, why can't I just ring you on my phone and say, hey, Claire, let's do a FaceTime and show you what I've got. And I think, I know I understand and appreciate confidentiality. However, sometimes if we are accrued to a ditch with a penetrating injury that you need advice about, that would be a phone conversation first, that you would have a discussion, and then we'll go, I don't understand what you're talking about. Hey, let's do a FaceTime or something like that. And
exactly. And I think, in our current practice, when there's a true emergency like that, then we have to accept that, there may be, I guess, non-ideal situations where we do have to use things that are less secure and where the sort of privacy issues may be an issue. But if it's a life and death situation, then I think we have to make that call as a group of clinicians to say, this is the situation and we have to do this because it's the only way we can best care for this patient, with an understanding that we are working towards having a system that means we don't have to use those systems that aren't as secure or as private as we would like them to be.
Yeah, definitely. Now, I'm going to take a different tack down a different road now. So we're at this scene and we're managing a patient. And so in the background, we've got screaming relatives and family members. And, you talk to a lot of pre-hospital clinicians and about what things bother them the most. And it is dealing, obviously, with paediatric patients and distressed family members. What advice can you give, or is there any special words that we can use as clinicians to help family members feel more comfortable, more relaxed, more informed, and just to help ourselves manage those types of jobs?
Yeah, absolutely. I think it's really important to acknowledge the emotions that you're sort of seeing in front of you And to be able to say to a parent, okay, first of all, I think it's really important to identify who's in the room. Sometimes you can walk into a scene in the same way you can walk into a hospital room and there's 5 or 6 people accompanying the child and you're really not sure who's who in the zoo. So I tend to walk in and go, I'm Dr. Claire, I'm one of the emergency doctors. If the patient's old enough, I'll say, hello, Johnny, who have you brought with you today? Because there's nothing worse than making an assumption about who's who and then determining that the family's situation is completely different to what you imagined. And children are really happy to engage and introduce who all the people are. And, that's my Auntie Joan and that's Grandma and that's, I don't know who that lady is. And that's, and so they're really happy to do that. And it's a really helpful way because then the family often feel involved as well, but they can see that you're engaging with a child. So that's obviously in a less critical situation, you can go through that. Otherwise, I'll often walk in and just identify myself and say, who's the parent responsible for this child? Mm-hmm. If you really need to know right now, who's the decision maker in the room? Now, culturally, that can be different. It could be a different parent depending on certain circumstances. So as an example, you might be in a cultural situation where it's the father that makes the decisions, the medical decisions and the care decisions around the children's health, or you may be in a situation where culturally it's the mother that does that role. And it's not for us to decide that. The families can identify who, or you might be in a situation where the child's in kinship care and it's actually an entirely unrelated member of the family who makes those decisions. So I just ask who's the responsible parent for this child. If there is no responsible parent, who identifies as the person who's able to provide that information right now. And that might be another member of the family. It might be a family friend or a professional even that's in the room. Once I've got that person, then I think it's reasonable to say to that person, I need you to determine who needs to stay in this room because this is a critical situation and I need to be able to work with you and the child. And I'm going to ask, could you ask some of these people to step out and wait, and we'll come and give them an update as soon as we can. And I think in those critical situations, it's really important to clear the space and not have people potentially getting in the way or getting involved in a resus that don't actually need to be there. And, sometimes, as you know, in prehospital, you can task another member of the family to actually deal with everybody else, depending on, who seems to be a dominant influence in the room. But once you've got that person, I'll often get them to sit down with me. Even if I am already working with a child, they can sit next to me and I can start asking questions while I'm working with the patient. And I'll often flag with them, I'm concerned that your child is very unwell. I'm going to work quite quickly to try and stabilise what's happening here. And I need you to just answer the questions that I'm asking you right now. I appreciate this is really distressing and really difficult, but what's really important for Johnny is that I get the information that I need to take care of him. Once we've got him a bit more stable, we can sit down and talk a little bit more about what's going on, but I really need you to answer these specific questions for me right now. And most families will go, oh yeah, okay, it's really bad. Okay, what's she going to ask me? It's not that they're going to be less distressed. And often we just have to tolerate that. If the person sitting beside you is going to cry their way through the questions, that's okay. As long as I can understand the information that they're giving me, it's really fine for them to be distressed. And it's just a matter of tolerating that and going, I'm really sorry, this is difficult for you. Can you tell me about what happened earlier today? Or can you get somebody to get a list of the child's medications for me, please? And I think it's about having that respect and just validating what's going on for them at the same time as you're managing the patient in front of you. That's something that we see happen all the time in sort of traumas, particularly where a family member may not have been present at the scene of the incident and then they've arrived in the hospital while we're working on the child. And even in sort of fatal trauma incidences, we will try very hard to bring a family member into our resuscitation because we know from the evidence that that's actually better for families than them not being involved. And so you do have that dual responsibility, I guess, then to the patient that you're working with, but also to the family who are going to carry this, really with them forever. And how you manage that family in that instance is actually really important.
Amazing. I love the
oh God, you've done it as many times as I have. What are you talking about?
The assertiveness and the confidence that comes out when you deliver it. And I think that's one of the most important things that clinicians need to do. It was firm, it was direct, but it was also compassionate and caring the way that you did it. So, hats off to you. That's the way it should be done, people. Listen to what Claire's got to say.
Yeah, just rewind 2 minutes. I felt I was in the room. I was looking around to see how my little daughter was doing because,
What did you want to know, Claire?
I don't need to check mine. They're all at school.
Yeah. Wow. No, that's great advice. Good.
Well, I think because I'm looking at the time and we're chewing into Claire's day. So, Alex, what do you think we move to those quick questions that we had fired up from
We got some rapid fire questions.
Okay.
And
nervous now.
thanks for people who sent stuff in on the social media. We'll get through some of them. I guess I was going to ask, maybe we'll have to pencil in a second podcast, but maybe just very briefly. So there's guidelines, and then there's a lot of conditions and presentations which don't have it. Croup, no problem. I think, any sort of first year paramedic student know exactly how to treat croup, because you just get the numbers, you get the respirate, you know which of the three severities it is, and then bang, here's the medication. So we don't have that for, and that's not true that it's that easy to treat sick croup. But also there'll be many presentations where there aren't guidelines, and conscious of time, of course, but what to do when people come with stuff that doesn't neatly fit into CPG number 1, 2, 3.
Yeah, I think it's about sort of, you're right, there can't be a guideline for everything, because otherwise I wouldn't have a job. And actually neither would any of you, because the families would just look the guidelines up on the internet and just do it themselves. And we see more and more of that, where families have access, particularly things like the CPGs, which are readily available in the community, and taken them to their GPs and said, hey, actually, this is what it says on the guideline. Can you tell me why we're not doing those things? And that's really great improvements in health literacy that we're seeing sort of over time. I think the reverse of that is, more vulnerable families or less health literate families almost have the opposite problem, where they're getting their information from less reliable sources on the internet, and then they're producing to you, as the person who sees them first, I think my patient's got, some complex disease process going on, where actually you kind of like, I think they've just got an upper respiratory tract infection, but the family have become really wedded to something that they saw on Instagram or on TikTok that they really think fits their child's symptoms. And it's kind of, how do you balance that? Because you're looking at the CPG going, well, I'm just going to use this kind of croup CPG. But the family really fixated on the child having some complex upper airway abnormality, and they really want to go to hospital. And you can't write a guideline for that. It's really about talking to families and seeking help. If there is a risk that this child's got something else going on, then it comes back to that phone a friend conversation, and whether that's sort of through AV pathways, if you're working pre-hospital and you need to call the clinician, or you need to call doc on call, or whichever of those processes you need to do to manage the patient, or alternatively, you're going to take them to an ED and just hand over, this is the family's concern, this is what I'm seeing. The two things are not really gelling together, and we're looking to you to try and, work around some of those things. So we'll never have a guideline for everything. Sometimes I see guidelines and I think, did we really need a guideline for that? And I think some of them, we kind of reduce things down to really, really basic levels, but that's kind of okay, as long as people are able to recognise that there's never going to be a guideline that covers everything, and some situations are going to sit outside a guideline, and that's actually okay. But they're the situations where we expect people to ask for assistance.
Yep, 100%. And I think that, is it highlights that point again of, phoning a friend or consulting with somebody else and involving other people, whether here in Victoria, whether that's virtual ED or whether it's doctor on call or another clinician or a higher level of care, whatever you actually need to actually do.
Yeah.
So thinking about quick fire questions, somebody sent in from Instagram was, what is it, or what can a parent say that makes you immediately more anxious about a child? What sort of things can parents give you that makes you take that case more seriously? That puts you on the spot.
Yeah, it does. It's interesting. I think it's actually not, there's no specific kind of things that a parent would say. It's more kind of that, it's more a vibe, right? Which is super helpful, I know, but it's kind of that thing where if parents are just really adamant that the thing that you're describing to them is not what they're seeing with their child, or sometimes you look at a child and go, they're just a bit quiet, but the parents are describing, this is not a kid who ever sits like this. Yep. It's not, this is really out of character for them, and I'm really not okay with it. I think that, there's different red flags for lots of different conditions, but, there's a handful of them would include things like a young child, like a really small child presenting with back pain, super unusual, right? Small children, early school years, preschool don't present with back pain. So if you're hearing, I really think he's got back pain, you need to look. Children that can't walk, doesn't matter why, if they can't walk, they don't leave the ED.
Yep.
Unless they couldn't walk when they came in because they're in a wheelchair, which obviously I'm not
Or
talking
really,
about.
really young.
Yeah, well, true, exactly. I don't expect 6-month-old to walk out of the ED. But it's, in a usually walking child, that now can't walk, that doesn't leave the ED until I know why. Yeah. And I've managed or. So there's a few things like that. In children, the big risk group is always children with fever, right? Because we know that more than 95% of those children will simply have a viral infection and they will get better on their own, and they are best not in our space where we can poke them with things. But there's a smaller cohort who will get very sick very quickly. And how do you pick those out? It's like a needle in a haystack, right? And we have lots of trigger tools and Victor charts and all these things that are supposed to help us, which they do in many situations. But I think it's really acknowledging that if parents are really worried about their child, it's not to say you need to take that worry, but you need to kind of understand what it is that they're most concerned about. And I'll frequently, when I'm consulting on a patient, I'll go in to see, and the registrar will have given me a very long history and presenting me a really well patient. And they'll say, but the parents want to see somebody senior. No worries. I'll go in, I'll introduce myself, I'll tell them what I've heard. So I understand that these are your concerns, but can you tell me the one thing that you're most worried about? And sometimes I'm really worried that my child has leukemia because my brother was diagnosed with leukemia at the same age. Now, the patient may have zero presenting symptoms of leukemia, but that's actually the thing that the parent is most worried about. Or sometimes it's just he's really not his usual self and I'm really worried that he's not going to get better. The parents are usually, when they're really pressed, they're really good at answering what it is that they're actually worried about. And sometimes it's totally different to what you expect. And then you just kind of have to go, oh, okay, yeah, I can see why that would be really worrying for you. But these are the reasons why I don't think that's an issue today. If you're really concerned, we can look at these things, but these are the sort of risk benefits of us doing all of those things. And for health literate parents, that's really valuable for them to have a little bit of insight into how you've made the decisions that you've made, rather than just being presented with an answer that they kind of don't really understand and are not happy with. So a lot of it is about having the conversation and the explanation.
Very good.
That was totally not a quick fire answer.
No, we just keep going. This is great.
Things we know about me, I talk too much.
What are you most worried about? It's such a good question. And I think they introduced that at 000, sort of on the call taking there, and that improved the accuracy quite a lot. And when you call 000, it's rapid fire binary questions straight away. Are they breathing? Are they talking? So that there's no question there initially, which says, what are you thinking? What are you worried about? And it'd be similar to someone who presents pre-hospital or in hospital. You get a duty doctor or paramedics sort of like asking these 20 questions that we've been taught.
And sometimes the parents are like, why are you asking me that? I'm not here for that. And you end up in a really weird place. And it's like, I know how you got there because I know what you asked to get there. But actually that was not the thing they were worried about. Or that's a long-term problem that they know about and they're totally across, but they've actually come for a different issue today. So I do think it's the most important question that we ask all our patients is, what are you actually most worried about? Because it often will direct you. And sometimes they're worried about the wrong thing. Actually, that sometimes the thing that you've seen is different to the thing that they're worried about, but that's okay. That's about sort of redirecting and saying, well, actually, I see what that thing that you've described, but I'm not worried about this because of this. The thing that I am worried about is this other thing that I've noticed. Have you noticed that? And it at least gets everybody on the same screen, because otherwise you're still in different books, and that gets really tricky to manage because you're not talking about the same problem. So I think it is probably one of the most critical questions that we ask in all the things that we're doing.
Right.
You got another question there, Alex? I've got another.
Yeah, mate. From Instagram here. I guess someone was asking, what are the subtle cues of deterioration in paediatrics? And an alternative was sort of someone else asked, what are some early signs? So I guess people want to know, a kid looks fine, and then where do you want to answer this question? What's the sort of first derangement to go, or what's the first thing you see that this could be?
I wish I could answer that question because I wish we knew the answer.
I saw that question.
There's sort of, I think a lot of it, I know, right? A lot of it is, and people, the registrars will say to me, how did you know that was going to happen? Or how did you know that was the patient to pull out of that cubicle and put in resus? And sometimes I don't know the answer. I know that there was something that didn't feel right. And it's probably a combination of lots of different inputs that are happening in the room that I am synthesizing without necessarily being aware of it. And I think a lot of it is exposure. It's, a very long period of time seeing these kids. And we call it gestalt, right? But I don't know that we have a really effective way of teaching gestalt yet. So we kind of have to rely a little bit on that asking for help and using the gestalt of the more senior clinicians to help you develop that yourself, which is not to say that junior clinicians don't have gestalt, because many of them really do. And it's that I've got a funny feeling, or the hairs are standing up on the back of my neck when I'm hearing a story or when I'm looking at a patient, that are making me go, something's not quite right here. This doesn't add up in the way that I expect it to. That's probably the big one. There's something that's not fitting. Like the parents are more distressed. The child's really too quiet for what I expect a child of this age to be. Or there's something that even though I've given a fluid bolus, or even though I've done this, the heart rate's not changing. It's not coming down like I expected it to. Or even though I've given the Ventolin, the wheeze is not improving and the child looks a bit paler. So it's like there are specific things that you can see in individual conditions, but how much of that is what makes us identify the patients that are sick versus not sick is tricky. And that's, it's the question we say, oh, are they sick or not sick? And I'll say that to my registrars every single day. Are they sick or not sick? And they go, oh. And it's like, I need you to have thought through that process. I don't need you to have the right answer necessarily, but I need you to have thought about it with every patient that you see, because that's what develops that skill of being able to say whether the patient is sick or not sick, is if you think through it each time. And sometimes you'll be wrong and sometimes you'll be right. And that's totally fine. That's learning. And that's why we have that backup of senior people available to help with that decision making. And if you're really not sure, or you don't have that backup, then that's a patient that you need to spend a bit more time with and look at again, or get them to a place where that more senior decision making is going to be able to occur. And either of those is totally fine. It's not that people have to have the right answer every time. It's about acknowledging there's something that's not right, or something that doesn't fit within what I know. And I have a feeling that I need to do something else. And sometimes they'll bring a patient in and we'll go, oh yeah, no, that's totally fine because it's X, Y, or Z. And that's okay too. That doesn't mean it was the wrong decision. It just is another point of learning to say, oh, next time I see that particular set of circumstances, I'll know that it's that weird thing that, it was when I took the patient to ED. And that's totally fine. There's no problem with that.
Yeah. And I think that's one thing that as paramedics or pre-hospital clinicians, they miss out on, is so that when you think about an average day in an ambulance service, depending on where you work with hospital ramping and all the rest of it that actually occurs, you may only see 2 or 3 patients a day. And those 2 or 3 patients patients most of the time will be adults. So your exposure to pediatric patients is very limited, and then your exposure to extremely well pediatric patients is extremely minimal. So it takes a long time to build up that personal confidence. So I think what you've said there is really important. And if you have any of that gut feeling or the paramedic concern, transport to hospital for assessment is my recommendation, and certainly that's backed by a lot of evidence as well. So
and the virtual ED that you mentioned earlier as well. If that's an option where you are, then obviously you can have that extra. And many times you'll see the virtual ED clinicians go, yeah, okay, I've heard what you're saying, but actually I still think this patient needs a face-to-face review because I also can't kind of really make a definitive decision based on what you've said, and that's fine.
Yeah, right. My final question for you, and I don't know if Alex has got one final one for you, but
he looks like he does.
Hundreds.
Oh no, I've actually got one which I want to touch on, but I don't want to talk about it at the end of the session, which is non-accidental injuries. So that's a whole nother podcast in itself for us to talk about. For pre-hospital clinicians, what is not non-accidental injuries at all? What is one thing that we could be doing better? As pre-hospital clinicians, what is one thing that we should know more of than what we do currently? Does that make sense? Does that question sort of make sense?
Yeah, I think so. I think that, honestly, it's that having the confidence to make an assessment. I think sometimes we still see pre-hospital clinicians go, oh, I'm really not comfortable with this. I don't really know what to do. It's actually to have that degree of confidence in your own capacity to do an assessment. Because I meet many, many paramedics who say to me, oh, I'm really not comfortable with kids. I'm really not sure about that. And I go, well, actually, show me what you do. Show me what it is that you're thinking about. And they'll show me things and I'll go, yeah, but that's exactly what you needed to do. That was exactly the right skill set. And actually, it's about having confidence that you can do some of these things, that you can make an assessment. And with that assessment, you can ask for help. And then, that person can guide you about what to do next. Yeah. It's putting the ego aside, I think, is still really important and is still sometimes an issue, to say, this is the assessment I've made. I acknowledge it might not be perfect, but this is the assessment that I've made. And then, to sort of say, oh, okay, that's great. Thanks so much for that. Because without the assessment, I can't do anything. So it's having the confidence to actually just say, yep, this is what I've found. And if it doesn't make sense, we'll be like, oh, okay, that's cool. Can you have another look at this thing for me? Because I'm not quite sure that bit adds up. And just tell me if you can see this, or this. And if you can't see any of those things, that's okay. And we can work with somebody making an assessment. It doesn't have to be perfect. So I think that's, we drill guidelines and we teach people to do all these different things. But as you said, exposure and training is still something that's really tricky now because of we care for people much better. They're actually just a lot less sick in the community than they were some time ago. And many of us trained in a situation where we didn't work in an environment of amazing patient safety, and because it just wasn't what was available at that time. And it does mean that those that are training now perhaps have less exposure to those solo critical incidences than what we did when we were training, which is much better for patients. But in terms of building up that skill set of managing those patients, as you said, it is a bit more difficult. So I think it's putting ego aside and presenting what you have done, which is often going to be completely fine, completely adequate, really great, and then acknowledging that it's a team and we can work on the actual outcome together, or the actual plan together.
Yeah, makes a lot of sense to me.
That's great. We're probably going to wrap up, don't we? But I was dreaming maybe if you had like 3 seconds. So if I'm, on the way to a job, or I'm in ED and I'm walking into the cubicle and I know what's going to be there, right? Or you get it on the DMT on the way to the job. If we could just have Dr. Wilkin in the ear to give a 4-second, make sure you check for this, or here's a little pearl or something. So, if I'm going in to see, let's say, a seizure, 4-year-old with a seizure. Now, there's hour-long lectures out there on what to do and stuff. But, I'm 10 steps away from seeing this kid. What are you going to tell me in my ear, please?
Don't panic. You know what to do. You've read the guideline. That's actually what I'm going to tell you. It's like, you've read this guideline. You know what to do. Just don't panic. There's going to be a lot of panic in the room. Don't join in. Just go in and be like, right, seizure. I do know my guideline. I know what I need to look for. I know that I'm going to draw up my dose of midazolam because I already thought about that on the truck on the way in. You've done that pre-planning in your head, because as you said, you get that information, sitting there on the MDT, or you've got it on the triage. Sometimes it's not perfect. Sometimes you walk into something totally different to what was advertised, and that's okay. I think my top tip for everyone is always make a plan for what you think you're going to go into. It doesn't mean you have to keep the same plan forever. You can make a new one. We're super good at that. It's why we do this work, okay? Because we can make plans. And there's 26 letters in the alphabet. So you can start with plan A, crack on in there with plan A. If you realize a few seconds in, this is not right, hit plan B. You don't need me to tell you that. You actually know what to do. Yeah. It's just, don't panic, don't engage in that and just crack through your guideline. And if you're getting to the end of the guideline going, it's not going well, phone a friend. Then you can have me in your ear, by all means.
Very good advice. Very good advice.
That's
now,
right.
Claire, I don't want you to panic, but all our guests so far have managed to do a 5-second dance for us that we can put into our intro video. So now you are under the microscope, and we would love to see you give us your 5 seconds.
Well, you see, I can totally do this, Shep. I will say my kids are much better dancers than I am, but they must have inherited it from somewhere, surely. Pretty sure it wasn't my husband. Yeah. So, I can totally do that.
Wonderful. Let's see it. Let's see, Claire.
Okay, here we go.
What's yours?
That's it. That's what we want.
There we go.
Perfect. Yeah.
Whirly chair. Yay.
That is wonderful. Wonderful. Thank you very
Pleasure.
much, Claire. It's an absolute pleasure to have you on the podcast with us, and I really do appreciate the time that it's taken to come and share your knowledge with us. We will definitely grab you for some further podcasts in the future, and that non-accidental injury, I think that can be a whole session in itself, which we love to discuss much later on. But for me, thank you very much, and I'm sure from Alex he'll have some words to say.
Yeah, thanks so much. That's great.
Yeah, absolutely.
No worries, guys. A total pleasure to be here. I'm super supportive of the work that you're doing. When we can get quality education out to people that's not necessarily kind of driven by organisations, it's really useful to people. And it's, if we can make it engaging and, people get something out of it, then I'm all in. So good job, you.
Thank you very much.
No worries.
Cheers. Bye.
See ya.